we have multiple guidelines from organizations that are telling us that medication is not first. That's second line. First line is behavioral training. And behavioral training is what we do. That is for incontinence, bladder training, and pelvic muscle exercise. And Aaron, I just feel like it is absolutely within the scope of every physical therapist training to teach pelvic muscle exercise. Yep. And I'd really love to share with people what the best words are.
Oh, please.
And these are words that we know based on imaging ultrasound. So we can see the recruitment, we can see the movement of the pelvic floor muscle, and we know that when you say these words, you have the best chance of getting that.
Hello, welcome back to the Cash PT Lunch Hour podcast. This is your host, Aaron LeBauer, and today my special guest is Beth Shelly. Beth is one of the pioneers in pelvic health physical therapy, and believe it or not, I've been following her in her pelvic journal club since 2012. I've just looked it up. I looked way back in my emails. God, it's 2012. So a few years out of PT school. Our mutual friend Jane O'Brien. Jane, I met her at an MFR course, and she said you got to look up Beth Shelly, and I did. And I've got a ton of stuff from your pelvic health resources. Even though we're not a specialty practice, I've just been able to use that to help so many people and so many women. So thank you. And thank you for being here. I really appreciate you taking the time out of your day, Beth.
Yeah, glad to be here.
Well, I'd love to start these shows because a lot of people may not have heard of you or known who you are. Some of the pelvic PTs listening will be like, oh, I know Beth. But I'd love you to spend some time, just like 1 or 2 minutes. Can you share a little history? How'd you get into PT and what turned you on to, how'd you get into PT and decide physical therapy is the thing for you? We'll start there.
Well, I was thinking originally I wanted to be a gym teacher.
Wow.
So that was my original thought. My dad was a teacher. He taught wood shop. And he said to me, no child of mine is going to be a teacher. Mm-hmm. He did not think very highly, in particular, of the public school system.
Yeah.
Well, I am a teacher. I'm a teacher through and through. I just don't teach in the public school system. But at the time, my mom was going through some medical diagnoses, and he was asking everyone in the hospital, what do you do? Do you like it? How's the job market? And he said, this is just like gym teacher, so go do this. And that's how I fell into physical therapy. Oh,
that's funny. My mom used to say, you should be a teacher. And I was like, I don't want to teach people that don't want to learn from me, because I was in high school. I was like, people don't want to learn, this stuff. But that's cool. So you went from not being told not to be a teacher to a teacher.
Right.
How many years did that take?
Well, I think I graduated in 1985, and I began teaching prenatal and postpartum exercise right out of school.
Okay.
So when I went to my first job and I said, this is what I want to do, I had already taken the landmark course from Elizabeth Noble at the time. And I really wanted to treat pregnant and postpartum women. So I began as an aerobics instructor there right out of school, and then started to teach physical therapists about pelvic therapy and obstetrics in 1993, when I worked at Elizabeth's clinic. Cambridge Physical Therapy at the time was owned by Holly Herman and Tricia Jenkins. Mm-hmm. So that was my start of professional teaching.
Oh, wow. That's neat. What was it that that occurred, or what did you learn, or what did you experience that you were like, pelvic floor physical therapy is my thing, or working with women or expectant mothers versus, I don't know, people getting knee replacements? I mean, what was there something that sparked your interest or really hit you pretty hard and you're like, this is my life's work?
Well, that is a typical story. I think what I hear at least is that women, as they're having babies, are thinking, wow, there's a lot of physical changes that are going on. There's got to be something we can do to help these people. Mm-hmm. And that's really where I came to, recognizing in college that there really wasn't anything. In fact, at that point, what they were saying is, you can do this and this, but not during pregnancy. And you can do that, but not with pregnant girls. And, just all over the board, it was, don't do anything with these women. And I had already had one child. And so I knew that there was a lot of physical changes, and I really felt like we had things to offer. So I was drawn mostly from my own experience. And that was, again, into that prenatal, postpartum side of things. From there, people started to tell me, well, when I go to exercise class, I'm leaking. And that opened up the door to the pelvic dysfunctions, eventually working into pain, and then men. Then we add the pediatrics, the geriatrics, and the neurology. And it's just been a wonderful ride.
Yeah, that's really awesome. That's neat. I think, like for me, it was, I came from massage therapy and, things that people thought were like, I've had people tell me all the weirdest things. And in PT school, people talk about pelvic health, pelvic floor, and they're like, I would never do that. I'm like, what do you mean you would never do that? I want to, to me, it's not an aversion. And to me, it was more of I'm a man and, I'm not 100% comfortable going into a room with a woman to do any internal stuff. And I still am not, but
there are men in the US that are treating men.
Right.
So that's really quite helpful. And I agree with you. I don't understand how women's health as a whole, or even pelvic health, the smaller specialty working with the pelvic floor dysfunction, I'm not sure how they are listed as alternative. Because really in Europe, in the 1970s, it was an undergraduate skill. It has been for many, many years in European countries, just like anything else, just like geriatrics or orthopedics. It's just another thing you can choose to specialize in. So I don't know.
Is it because sex is a stigma in our country, and so
you wouldn't think so? I mean, goodness, in England, we learned originally from Joe Laycock in England, and they're a lot more conservative than we are. And I think it's getting better, though. I hear more and more that students are coming out of school with an interest, which I think is really healthy. We have over 15 residencies at this point in women's health. And I do believe it's becoming more accepted as another branch of physical therapy. And truthfully, half of the population that you're seeing in your clinic is women. So you're treating them whether you think you are or not. And with the percentage of women that we know are leaking, you are treating people who are leaking without even knowing that they are. And that's really a loss, especially when you consider in the field of orthopedics, we know so much about how the pelvic floor contributes or doesn't to back pain and issues of stability. So more and more, I think it's accepted.
Yeah, I think and it's really great. A friend of mine here in Greensboro, Wilda Young, you may or may not know who she is, but she owns a pelvic health and women's specialty practice here. I think at one point she couldn't find another thing. There was 6 years where she couldn't find someone else who had actually wanted to do it with her. And I think it's great. I agree with you. There's younger students, but is there some other reason that this is ignored, or is it just our ignorance and marginalization of women, female bodies?
Yeah, I think, as I said, it is getting better, and people are realizing there is a big role for this. And, I work with a lot of colleges, and there is better education for the first professional students. So there's, I think, less resistance.
When I went to school 12 years ago, and there wasn't that much. It was oh, well, Duke has a women's specialty practice if you want to do a rotation there. And that was the extent of it. But we also did 2-3 hour labs on soft tissue, and no one wanted to be my partner because I guess I was a massage therapist and they were intimidated. So what's the biggest thing that you've seen change in terms of women's health or pelvic health, PT specifically, in the last 20, 30 years since you've been doing this, teaching it?
I think the biggest change is the WCS. So this is Women's Health Certified Specialty. It is a specialty through ABPTS. It started in 2008. And that was the first specialty that had been added in over 15 years.
Wow.
So it was really a big accomplishment. We worked for many, many years in securing what we needed to, as far as the number of people who said they were going to sit, and there was funds that were raised, and the DSP had to be created. But since that time, it has just been a snowball. We're over 500 now, which is more than electrotherapy, the very first certification. And there's another one that has not very many. I can't remember which one. But
I only know the top 4 or something.
Well, it's growing. It's growing. And this is something that I have done for probably about 8 years now, is to mentor those who are working towards their WCS. It's a big test. It costs a lot of money. There's a lot of things to learn. And unfortunately, if you don't study in the right way, you're going to spend a lot of time working that doesn't help. Yeah. And people have failed, sometimes even twice. And they, it's just really a thing that people sometimes find they need direction. But with that change, I think we have come up in the understanding in other countries. So there are other countries that have these kind of certificates or certifications or board distinctions, and we never could compete with them because we didn't have anything like that. Right. But now internationally, we are more highly regarded because we have the board certification.
Yeah, that's great. And what has that changed for our profession? Like, what has that changed for the people that are board certified now? Like, is there something different, or is it the education on the way to the certification that really is more meaningful?
Well, as you mentioned, just studying makes you a better therapist. And when you're a better therapist, you have better outcomes. And when you have better outcomes, then you have a better business model. So it is that as well. But there are some organizations that are providing financial incentives that you are stepping up the ladder if you are board certified. There also is incentives if you are a teacher or a researcher, because you are more highly thought of. Right. So I think it just elevates the whole practice when we have this distinction of a specialization. And one thing that's a little bit different than, for instance, orthopedics, pretty much everyone has a good basics of orthopedics. So when you step into the specialty of women's health or pelvic physical therapy, people think they are a specialist. But that's not true. It's just not the way it is. So it, again, brings that up to a higher level, that now you are a specialist in a specialty. And really, it can be used in marketing. It can be used to speak to physicians. It sets you apart. Even in my local area here, I'm still the only one who has that distinction.
Right. And while we're on the topic, Beth, can I assume when you graduated PT school, you had like a bachelor's or master's degree?
BS, right? Yes.
Okay. So, and this came up, this has been a thing that, people struggle with, I think, or triggers people in our profession. You have a DPT degree. So you've gone back to do your transitional DPT.
Yes.
I want to know 2 questions. Like, why did you feel like that was important? And why did you feel like that was important for you to do? Because you're already a specialist, probably top of your game, teaching other people. Like, why was it important for you to go back and get that degree?
Well, there's something to clarify there, because I got my DPT before the WCS was even available. So I didn't have that choice. I didn't have the choice to be board certified. So there was really no distinction that set you up as a professional. And I did go back for the DPT because I felt that was a way to, again, elevate the profession, to help physicians understand that we are at a higher level than people that they write prescriptions. I graduated in 1985. And when I graduated, we would get a prescription that said, hot pack, ultrasound, and massage 3 times a week for 12 weeks. And that's what we did. And it was just ridiculous. And even then, I knew this is not the way I wanted to practice. Right. But it was the standard. That's how we worked. Very quickly after that, I couldn't tell you the exact date, but Massachusetts was one of the first states to have practice without referral. So when I worked at Elizabeth Noble's clinic in the early 1990s, we did that. People would come in off the street and say, I'm leaking urine. And I would say, great, let's see what's going on. And if you need the physician, we'll call him in. So this was the way my practice was going from the beginning. Whether you call it a doctor or not, I think we practiced at that level way back in the 1990s. Yeah. And I think differential diagnosis is one of the things that sets us apart as an entry-level practitioner. And that's what I strive for as a specialist. And that's what I focus on in that WCS training.
Right. And I think it's important what you said is it wasn't, it's almost like when what I'm hearing is it almost wasn't as important to have the degree as it's the learning, but also practicing at the level of a doctoral profession is more important than and being able to do the differential diagnosis, bring people off the street and feel comfortable, more important than the letters. And the letters are basically the signifier that I've achieved this level.
Yes.
Is that right?
Yes.
Because I think that when I post something on Instagram about how we should be proud to call ourselves doctors and people get triggered by it and they're like, well, what about me? And what about this? I'm like, it's about the level at which we practice, because physicians don't know what we do that well, and patients don't know what we do because they still think we do the hot packs, legless, and ultrasound. But what we have to do is be able to speak to them in a way that's we're confident that we can take care of them and we know what to do with them if we can't. Wouldn't you agree?
Yes, absolutely. Yeah, it's a thought process.
Yeah. So and you I'm just saying, Beth, I'm just impressed that you articulate it really well, and I just wanted to have to repeat it because I think it's important, because there's all the other things you've done to me. Like that's the one thing. It's like you're operating at the highest level of profession, regardless of the letters behind your name. So
yes,
I want to applaud you for that. But I think that's important. That I don't think people are getting that today. They're either taking it for granted or because they haven't seen the struggle that you have for the profession. Right?
Maybe that's part of it. It's a historical thing, and people who haven't had it, didn't have the choice to have it, are very grateful that we do have it.
Yeah. What else is, whether it's women's health or pelvic floor PT or not, what else have you seen change over the years in public's perception or in our profession that, some of the people who are even younger than me listening might, benefit from?
Well, another thing that I think has changed is the patient. Because when I first started, the patient came and they were passively receiving a treatment, and then they went home. And we already know that that's not successful. That's not as successful as when the patient and the therapist are at equal plane and both working to achieve the final goal. I think that patients are more involved, as they rightly should be. Yeah. I get a little upset about Dr. Google, and sometimes people coming in thinking that they know and having read something that it may not have applied to them at all. But if you are able to articulate well, then you can explain things, even if it involves very private parts. Right. And that's a thing that takes a bit of skill. But even orthopedic therapists, you must be able to explain, why am I asking about your sexual function? And why do I care that you're leaking urine? Because those things are important to your practice as well. And I think patients are able to understand if you are able to explain it well, but they really are more involved than they used to be.
Right. What's the question here? And I'm going to say this I'm a guy, I'm just really into lifting, or I don't really do, maybe I'm just a therapist, whether I'm a guy or not, but Aaron's the guy. And I'm actually into cycling, not lifting. Why would
that's even worse.
Right? Why would I care? Or why would I need to ask one of my patients, tell me about your, you have any sexual health or leaking, why would I care? And then what I think the goal is what's the exact wording that I could use so that I don't feel weird about it, and my patients don't feel weird about it?
Yes. So this is how I approach the question to my students. I teach at the local university here, and I do several different facets of their women's health program. And one of them is the assessment. Yeah. How do we ask questions. And one of the exercises we do is to practice using the words and asking questions. So I do suggest that therapists look into the mirror, hold eye contact with that person, and say the word vagina. And say it in a way with confidence that does not feel like you're asking the wrong thing.
Yeah.
But as far as the words, what I would suggest is that every physical therapist have on their intake form 3 questions. And if you put it on the intake form, then it comes up a little bit more easily, and it's a little easier to start the discussion. So the 3 questions are, do you leak urine? The next question is, for women, do you wear a pad for anything other than your cycle? And then the third one is, do you have pain during intercourse? So the first 2 are trying to identify a person who might have weakness in the pelvic floor, which can compromise the core and can be important if that's the area of the body that you're working with.
Right.
The other question, the question about pain during intercourse, is more related to spasm or contracture, which is often a pelvic pain contributor. Can contribute to sacral pain because it tethers the sacrum. But those are the 3 questions that I would suggest everyone ask. Yeah. Now, I don't know if you had this book, but it is a very common book being used now in the PT school. It's called Differential Diagnosis for Physical Therapists. Did you use that book?
Yeah. Yeah, we did.
So it's been around for a long time. I've been involved in 2 edits up to this point, and giving my perspective from the women's health pelvic therapy angle so that people are able to incorporate these things into the various locations. Right. And there is a series of thought process that would take you to, do you have numbness in the saddle area? That's a really important question for a person who's a cyclist. Right. Because that sitting on the saddle can compress the pudendal nerve on the inside of the ischial tuberosity. And then you have a neuralgia, which can result in motor and sensory deficits as well as pain. Right. So you have this technique of recognizing what might be connected using that differential diagnosis process that would lead you to asking the questions. Yeah. And then you know the question that you're supposed to ask at the end. Is there anything else in any other part of your body that's going on at this time?
Yeah, absolutely. But, Beth, in PT school, we were taught to ask how many steps they had going into their house and do they have a handrail or not.
Oh, that's the differential?
Well, that was those are the questions I learned in PT school that stuck out the most. I was like, why are we asking these questions? Like, I get it if I'm discharging someone from the hospital, maybe. But I think it just gets, these are much more important questions. And the reason I bring it up is because they're much more important questions for people's daily life and function. And I was never taught to ask these questions.
Yep.
No, not in PTs. I mean, I had to go learn it myself. And I don't even, I would say, I'm not sure we ask all 3 of those on our intake forms. So,
it's a great business thing, because if you do have access to somebody who's treating the pelvic floor, you ask that to every single patient that comes in, you are generating patients for that person with the pelvic skills.
Yeah, that's huge. Gosh. That was so great. I'm like, all right, when I get done with this, I'm going to go listen to recording, make sure I have those, because I think I know it's important, and it's important. And I think that, and you brought up the best point, like this generally is a business podcast, but I like to bring in people who have different specialties, but it's like, can I identify something where people need help and no one else is really going to help them with this, like most of these problems are mismanaged. I think. I mean, in my experience, like, do you see that too?
Yes. They have pads, loads of them, and then they're given medication. Yeah. And, we have multiple guidelines from organizations that are telling us that medication is not first. That's second line. First line is behavioral training. And
Mm-hmm.
behavioral training is what we do. That is for incontinence, bladder training, and pelvic muscle exercise. And Aaron, I just feel like it is absolutely within the scope of every physical therapist training to teach pelvic muscle exercise.
Yep.
And I'd really love to share with people what the best words are.
Oh, please.
And these are words that we know based on imaging ultrasound. So we can see the recruitment, we can see the movement of the pelvic floor muscle, and we know that when you say these words, you have the best chance of getting that.
Mm-hmm.
So here are the words. For women, the best description is hold back gas. And I would add to that in church.
Mm-hmm.
And the reason I say in church is because I don't want anyone else to know you're doing this.
Right.
It is not squeezing the butt. It's not moving the legs. It's not pulling in the belly. It's not holding the breath. It's not squinching the face. Nobody should know that you're doing this on the outside, but you can recognize that squeeze because in particular women have a very large portion of their pelvic floor posterior. Mm-hmm. And it's usually preserved from trauma of childbirth. So hold back gas for the ladies, gets the elevation. The instruction stop your pee is what we started with many years ago, but we actually have some data now that tells us if people actually do practice stopping their urine flow, they are creating dysfunction.
Wow.
They're creating a scenario where the bladder only squeezes part way and does not fully empty. So it's not a good plan. And the really bad thing is if somebody's having trouble with leakage, they can't stop their pee. So telling them to stop their pee is frustrating. It's not helpful in any way. So hold back gas.
Yeah.
For the men, we actually have two instructions because for men, the front portion of the pelvic floor is much more influential in the bladder, and it is very different from the ladies. So men will also benefit from the instruction, hold back gas. But simultaneously, we're asking them if it's possible to pay attention to two areas. But the best instruction for the men is shorten the penis. Mm-hmm. So that motion of pulling back in the front is the one that causes the compression of the urethral sphincter best. Now, we have to develop other little tricks for people who are having more difficulty, but at least 40% of people can understand those instructions without a vaginal or rectal exam, without biofeedback equipment, with only verbal instruction. So you can have a pretty good shot at instructing your orthopedic patient how to do this with those words.
Yeah. Wow. That's awesome. That's really great. So, hold back gas like you're in church. Hold back gas. My words don't always come out right. And then shorten the penis.
Yes.
Perfect. Okay. What about those people that have like overactive pelvic floor muscles?
This is a bit of a challenge to identify, but as you can understand, if you do strength training on a person that has a muscle spasm, it's going to make it worse. Mm-hmm. So the recommendation, as you learned, is to proceed for 1 month. And if they're not better or if they're worse, then you got to get more input. So that's my first suggestion. Okay. But I would ask more questions if there was a pain scenario. So we've got the pain with intercourse, pain with sitting in the perineal area, or tailbone pain. And pain from sit to stand in the tailbone is hallmark of that area. The occurrence of urgency frequency, where you have to really go to the bathroom very badly, that can be a weakness condition, but you have to be careful that they know how to relax as well. Constipation is another thing that can be related to that constriction and that holding situation. So in these conditions, what I do, and this is the world according to Beth, but you're welcome to use it, and that is an Anti-Kegel. Mm-hmm. So Dr. Arnold Kegel was a guy, in the 1940s and 50s and 60s, gynecologists that used a pressure biofeedback device inside the vagina to teach women how to squeeze the muscle so that they would have less leakage and better sexual appreciation. Mm-hmm. So Kegel exercise technically is strength training. The Anti-Kegel, therefore, is not for the purpose of strengthening or squeezing better, but for the purpose of relaxing better.
Right.
And again, we have both pressure and EMG data that tell us if you do a small squeeze and then a big relax. Contract, relax is basically what we're using. Mm-hmm. But we do know that this is helpful in being able to relax better. Right. So I'll teach them to do that, small squeeze and big relax, and only have them do 10. So small number in a relaxed position, focus on the relax. And if you use this, please make sure when they come back the next time, you ask them how they did it and you make sure they understand. So I always say to them, so this is a test. Why did I ask you to do that exercise? Mm-hmm. And I would say still about half the time people say, to contract better or to squeeze better or so that I don't leak or something like that, which is exactly wrong. But somehow they all feel like the squeeze part is the important thing. Right. So you have to just check to make sure they understand the relax part is key. Yeah. And then, of course, I have EMG and imaging ultrasound that we can see it better.
Is there like a visualization that helps with that? Or is that just confusing for some people too?
No, it's not necessarily confusing. The pelvic floor is kind of like a bowl. So we have mm-hmm. this bowl here going this way in the body. And when it squeezes, it goes up. And I would want to make sure that they can recognize, okay, I feel when I squeeze, it goes up. But even more importantly, when you relax, it goes down. Mm-hmm. So I encourage them to think about down towards the feet. Right. Now, there have been some, in particular, in the alternative realm, who have used visualizations like, imagine the sit bones are separated. They actually don't separate, obviously, but if you have a good ability to imagine, to visualize, to use your mind to affect things, that separation is part of the lowering. But it is a lowering towards the feet that is most helpful. And then you have people remember, what does it feel like when you release gas? What does it feel like when you move your bowels, if you can do that well? And that's the signal of relaxing.
Got it. Is there a difference, like with the cues for men and women? Is that a like a more of a visual thing, or is it there's an anatomy kind of contributor? Is it like the way our pelvis sits or stands, or is it mostly just a pregnancy contributor that you think might be different, or you know?
Yeah, I think there's a lot of ways we can go with that question.
Yeah.
So let's talk about guys for just a sec. All right. So men pee standing, the majority of men pee standing. And the amazing thing is this, I don't have this structure because it's not what I do, but I ask a lot of questions to a lot of guys. And I must think that in the public male bathroom, there's this whole thing going on. Women have no idea. All of the things that you do this, you don't do this, you got to look this way and don't touch this. That's a whole thing. Ladies, you have no idea.
Well, we have rules. You guys have like a lounge area or something like that, right?
Just shut the door and do what you do. But just think about this. You're in the standing position. A man has to get a little bit of hip extension in order to shut off some of the hip muscles, because when you're contracting the glutes and the adductors, you're facilitating the pelvic floor, and you can't relax completely, and you're not going to empty completely. Right. So you've got to get a little bit of hip extension to shut off those muscles. So think about the Parkinson's patient who can't get to neutral, never mind into hip extension. So we kind of have that scenario as far as position going on. Then we have the amazing ability to relax the front, but keep the back. And I understand that sometimes it doesn't help and you have a release of gas when you're peeing, but oftentimes there is that ability to differentiate between these muscle groups, where in women, that isn't the case. It's just relaxing completely, all front and back.
Oh, wow.
So the positional issues are very quite interesting.
Yeah.
We know that when you're in an anterior tilt, you have better support in the pelvic floor, so that people who have a flat back tend to have more prolapse. People who have a lot of an arch, like the African American community, they tend to have less prolapse. It activates better or best in the neutral position. It works with the diaphragm. Here's another very good caveat for that pain person.
Yep.
The respiratory diaphragm going this way and the pelvic diaphragm going this way, they are buddies. When you breathe with the respiratory diaphragm, it descends. And in order to keep the pressure in the abdominal and pelvic cavity stable, the belly is going to pooch out. That's how we know, right? But the pelvic floor relaxes down. So inhale should have pelvic muscle relax. And so in telehealth, what I'll do is have people on a relatively firm chair where they can feel the sit bones and pay attention to the perineum, the space in between. And then we practice the diaphragm breath and notice that the pelvic floor is coming towards the chair during the inhale.
Wow.
And that can help in the process of getting that muscle to release.
That's such a great little tidbit. I mean, I'm sure that's helpful for a lot of people right now. Are there any other little tricks or signs, like when a patient tells you this, like you should ask it? Like, so we've got these 3 questions on the questionnaire, but like, say my patient with back pain or hip pain or whatever. Like, is there a question or a what's it called, like a practice pattern that you identify, like pattern recognition? You're like, when the patient says this, you better ask this other question, whether you're a pelvic floor therapist or not. Yeah.
So one of the things that I would like to challenge everyone to consider, especially in the older population. So we're talking about people who maybe have a little bit of a balance difficulty. We're trying to do some strength training, certainly applicable to the homebound elderly. And that is, how many times do you get up at night to go to the bathroom? Now, what I'm talking about is not the pee before you go to bed and not the pee that you get up to stay up for the day, but what is going on in between that, where you sleep before and after. This is called nocturia. And we know that if older people are getting up 3 or more times, they are more likely to fall and break their hip. So now we have a big impact. We can have a very big impact in this person's ability in, going forward in life, whether they're going to be in a nursing home or not, by helping them to be able to do better at night. So how many times do you get up to go at night? And if they get up 3 or more times, now we have to get into, what do you do? What kind of things could be helpful? Not only do you want to make sure that the track to the bathroom is clear, so you want the usual things you would think of, like a night light, no obstacles in the way, no throw rugs, make sure the walker is close, all of these things that we would do already, but also, what are you drinking before bed? Now, sometimes people get this idea, if I stop drinking before bed, then I won't get up at night. And they stop at 3 or 5 p.m. That's way too early. It takes about 45 minutes, but to give a space for the bladder, the kidneys to create, I ask people to stop drinking 2 hours before bed. So if they go to bed at 9, they're going to stop at 7. And that allows them to pee whatever they have just had out before they go to bed. And if they're sleeping deeply, this is very interesting. Our kidneys make less pee per minute if we're sleeping deeply.
Wow.
So sometimes it's a sleep problem that's making them make more pee. But oftentimes they're getting up because their shoulder hurts or their hip hurts, and they figure, I might as well go to the bathroom. Don't do that. It's not good.
Well, I think this is,
go back to sleep.
I want to bring like why this is so important, and because I had a family member who fell recently, fractured their femoral neck, and had a reduction, like the, the screws, ORIF. But I'm like, this is a problem. Like she needs physical therapy and I looked up the stats. It's like there's a 25% mortality rate within the first year for someone over 75. Mm-hmm. Like that's a huge number. That's a massive number.
It is a big impact.
Yeah.
Very big.
Yeah.
Yes.
And 50% of people are discharged to skilled nursing. And I was just like, these are big numbers.
And you can influence, potentially, that by asking that one question: how many times do you get up to go to the bathroom at night? And then working towards helping them to understand they shouldn't if they really don't need to go, or getting them to somebody who can get a little bit more clearly why and what should be done.
Yeah, absolutely. I think that's such a good clinical pearl. And I think that's that's like this underserved area that we as physical therapists do that people don't appreciate, because one, it's like, well, patients like, it's never going to happen to me, and when it does, they don't come see, they don't really have the opportunity to come see us because they're in the emergency room in surgery. But I'd love to know, like, a big part of my question, and I'd love to know this from your experience, I feel like physical therapy is missing in the conversation around the opioid crisis, around, in the hospital, like when we had our kids, like there was no physical therapy. Like what do we, and I've got so many things I could say about that, but like, what do we have to do as physical therapists to be part of this like conversation and around people's normal daily lives and, around these big issues and big areas? Because half the population has babies. Yep. And 25%, if you fall, you're gonna die over 75, 25% chance. And 55% of people who reported back pain were being prescribed opioids in the past decade. How do we become part of this conversation?
Right. And I think whether we like it or not, physical therapists are educators.
Yeah.
And one of the groups we are educating is patients. And I think, especially with social media and the ease of accessing information, I think that it's important that physical therapists produce educational materials, even little snippets that go out over and over and over again to patients, to be able to start these conversations and help them to understand. This is one of the things that women's health physical therapists do in great fervor, and that is the obstetrics and the postpartum moms, to help them to understand that there are things that can be offered. I think that they are searching for something, but they're not sure what they're searching for, and they don't know where to get it. And the original way that we tried to make this happen was to go to the physicians and educate the physicians. I think midwives may be a little bit more interested in learning some of these things, but physicians have so much on their plate, and for them to have all of that recognition, maybe it's just not realistic. But I have banged on a lot of doors and brought a lot of donuts, and it didn't help. That's just the way it is. But I think the other angle that is occurring, I am very pleased with, is what is happening with our national organizations. So the APTA, I was just reading, is really working on the opioid issue. And they're really working towards increasing the awareness, not only to the patients with their branding and who they have access to, but also to legislators and to insurance companies. And they are our voice. I think they have been doing a good job. The Pelvic Academy, of course, is for women's health or pelvic therapy. They have a whole postpartum thing going on right now. So those groups, I think, are very useful. And I just saw a post on Facebook today. Are you a member of the Pelvic Academy? Why or why not? And I can tell you with a great deal of certainty, since I graduated from school, I am a member of APTA. I have always been, I will always be, and a member of the Pelvic Academy. And that is because they support us in so many ways.
Yeah, that's great. That's really, yeah. So, here's my contrarian question is going to be, Beth, you graduated in 85. You're like, oh, look, I'm 47, but I want you to help the people that are between the ages of me and you, which you're like 5 months older than me, I'm sure. But really seriously, I work with so many physical therapists who are like, I just can't do what you just said was so important. how do you overcome this technology? I mean, like Facebook, Instagram, which I didn't grow up with. I'm not that great with. You know, I grew up with an Atari, and I only had it 5 years after all my friends did. What would you say? I want you to share, like, how with the other physical therapists in your generation, how can they understand or easily understand, like, how to get their message out to people, like in the same ways you have, like through you know, in public through social media, like, because it's like there's some block, and I maybe you've had this or not, but you don't have it right now. So
Well,
is there something you can?
had it.
Yeah.
I have had the block.
Right.
I
How'd you
have
get by it? How'd you get by it?
I have had situations where I stuck my heels in and I said, I am not going to learn this. I'm not going to go this way. Right now, I'm kind of working through Google Docs and Google Drive and storage issues with all of these things that I've created now. I've got to store them somewhere and easily access them. So what I would say is surround yourself with people who are able to understand and help. The Journal Club is a really good example of this. I started the Journal Club in 2010, and I started with the people that I knew were teachers, inviting them personally to take a month and to, you know, be able to provide this service of reviewing articles. But as time went on, I would send out through the Journal Club email and say, look, I need somebody to help with a blog because we got to be able to load these things somewhere. And then, so I have this girl now who's a really helpful blogger, and I just send her my stuff and she puts it where it needs to be or changes the color or whatever. Yes. So I have work to surround myself with people who are have different skills. There's one girl who helps me with MailChimp. I have another girl that's working on some of the things related to Instagram. I have an Instagram account. I don't know if you've seen that. The Journal Club is over, I don't know, 1,000 followers. I never get on it because I don't know how to. I let the other girl do it.
Right.
But I think for me, I am the kind of person, I'm not worried about technology. When EMG first came out, I didn't look at the book. I just got on the machine and I just clicked around and what does this do and what does that do? So maybe that's different from some of the people of my generation. But that's how I got into Facebook, is that I just started clicking around and trying different things and connecting in different groups and posting things. And when the quarantine hit and I started to put things in about telehealth, I could not believe the response. And I was like, wow, this is how it works. Now I'm in there. I get it. So it was really quite a learning experience in that way.
That's awesome. Thank you for sharing that. You know, it's my dad, like I've had to tell him twice this year, like to delete a video. It's Facebook Live of his forehead. My uncle's done the same thing and they're like 85. I'm like, yo, you guys delete that. They're like, I don't know how we did that. They had to press like 3 buttons to get there. But I think it's important because what you said is it's our duty to get this information in front of people and create content. But if I can't figure it out, it's not like, how do I do it? It's like, who do I find that can help me do it? And I think that's what I'm hearing from you. So Thank you very much. Beth, there's probably 20 other questions I have, but we're about out of time. I'd love to know, can you share a little bit about, like if someone's interested in the Journal Club, like where do they find the information about that, or how do they go about getting on the notification list? I'm not sure if it's an email thing anymore or if it's a membership site or something different, but I'd love you to share how to find that now.
Right. So my website is my name, bethshelly.com. And I am in the process of redoing that as well, my more techie things. But right on the homepage, there is a button that says Journal Club. And when you open up that page, you will see information about the Journal Club. It's completely free. We usually hold it on Wednesday night at 7:30 Central Time. The first Wednesday of every month. But, you know, all that information there, you'll see the schedule. It's done up for 1 year. And there is a link that's a sign up link, and it's a MailChimp situation. So you just put your email in there, you're automatically into the email. And whenever the articles go out, 2 articles every month, there's a full article, unless we have issues with copyright and we have to just post in the link to where you would find it or download it. But most of the time they're PDFs, and then the recordings are done so that you can go back and listen to the recordings. That will come out again in an email, and if going to the blog will take you there. But that's where you can find other information about other educational products that I have, the WCS mentoring. I have a page that says free stuff. So I've listed links to like AUA guidelines and things that would be of interest to people in the field there as well.
Great. Thank you very much. Yeah, I know it was really stuff that was really helpful for me when I was getting started, and I had to go out and find like the right information, and I found your stuff back in. So it was was it 2012, which seems like a long time ago, but that's only 9 years ago now. So thank you very much, Beth. If there's one more thing you have to share, or maybe a question I didn't answer, is there something that you think would be important before we finish up?
Well, I would say that the field of women's health and pelvic therapy is a wonderfully growing field. And if you're looking for a place to expand your business that you're probably not going to have very much competition in, this is the place to do it. Yeah. It's a really very quickly growing field. And I think people can have a great deal of success in business adding that to their model.
Yeah, I absolutely agree. Some of the people I work with whose businesses grow the fastest or expand the quickest are specializing in pelvic health, or adding it to their services, and actually educating people about it. So thank you for that. Yeah, I think that's absolutely, you're right. So Beth, thank you so much for being here. I really appreciate your time. I've learned a ton, and I'm sure if I learned something, the people listening have learned a lot too. So
I hope
thank
so.
you. This was a pleasure. I look forward to meeting you in person one day when travel resumes and all those things. But until then, thank you so much. And this is the Cash PG Lunch Hour. Appreciate you, Beth. And this is Aaron LeBauer, and we'll see you guys on the next show.